Thank you all for coming. I'm looking forward to a great discussion with leptomeningeal disease experts and led by Plus Therapeutics. First, we're going to have Dr. Peter Forsyth from Moffitt Cancer Center, who's the chairman of Neuro-Oncology at Moffitt. He has been great. He does leading research in leptomeningeal disease, and we're excited to have him give a talk today.
Thank you. It's been a while since I've heard "Hold Me Closer, Tiny Dancer." Anyway, thank you very much for coming. I'm just going to talk about leptomeningeal disease. I do have too many slides, but the details don't matter at all whatsoever if you can just concentrate on the concept. I think the major thing that I wanted to get across is that the capacity to dream and have a vision is a very human characteristic and property. And I think when we think about dreaming and having a vision, we want to cure leptomeningeal disease. These are my disclosures. I wish they were longer. This is an outline of the talk. So as you know, leptomeningeal disease is a terrible disease where the average survival is just a few weeks or a few months, and it's incurable. So like every good talk, I just started by telling you a lie, which I want you to be aware of the lie, and that is that leptomeningeal disease is curable. So it's curable in patients with leukemia, it's often curable in patients with lymphoma, and every once in a while, patients who have solid tumors, it's also curable. So we need to change our attitude about that. Just going to talk a little bit about the biology. The other problem is that we can't say that something's incurable if we don't understand it. So imagine that there's a bunch of aliens floating above Baltimore that wanted to invade, and then you would see this alien spaceship and say, well, geez, we lost the battle, when we don't know anything about the aliens at all. So you can't really conclude that you can't deal with something if you can't understand it. So we've really been a little stupid, in my opinion. So one of the major problems is leptomeningeal disease is really great if you're lazy, because there's only about 8 or 10 papers about the biology of leptomeningeal disease, which you can read really quickly. So again, we can't say anything about us not being able to cure it. So this is one of the first papers showing that Adrian Bohr showed that there was interaction with complement C3A in cancer cells that led to increased permeability of the choroid plexus CSF barrier and let tumor cells and growth factors in. I'm going to summarize 6 of these. The second is also by Dr. Bohr, where she showed that there was a CSF is harsh and nutrient poor, and there's very low levels of iron, for example. So this is a therapeutic vulnerability, which is now a clinical trial that Jessica Wilcox is running in Sloan Kettering, using the intrathecal iron depleter desferoxamine. This is a toss away point, but all these cells have a unfolded protein response, which also makes them vulnerable in many ways. So it's a iris-dependent, non-capped mRNA response, for which there's several commercial inhibitors. We just ran out of time to do this ourselves. And then Dorothy Sipkins observed that the breast cancer mice that she was working with, the 0771 mice, I think, in Duke became paralyzed and would drag themselves along the floor of the cage by their front limbs. And it turns out that the tumor cells would invade from the bone along the emissary veins and be helped along by macrophages that secreted GDNF. So this is a pretty remarkable second way of getting tumor cells into the CSF. And then there's 2 more papers by Dr. Smalley doing spatial transcriptomics, for example, and looking at the interaction of the tumor cells with the dura, the Peel cells, not the dura, and uncovering some therapeutic vulnerabilities. And the second is also by Dr. Smalley, where she wanted to do metabolic profiling of the CSF, which I told her was like a really bad idea and a waste of time. And she discovered that the elaborated branched chain keto acids, which accumulated, which is similar to maple syrup urine disease. So as you might remember from medical school, because I didn't, is that there is a treatment for that, which is sodium or glycerol phenylbutyrate. But more importantly, when you give these drugs to animal models, the mice survive longer with LMD, and it reverses the neuronal damage that occurs. So like most people in the room, I see patients who are pretty confused, and you think, oh boy, it's hydro, it's all those tumor cells. There's clearly a bunch of factors, and this is probably one of them. So that's kind of it for the sort of science papers, leaving one or two aside, and then there's a whole bunch of pretty cool trials. You're about to hear more about this. I've already talked about this one. Emily Lebrun has it's actually Nevo and IPI, which is not open to accrual anymore. And then Jonathan Yang has the randomized trial of the proton cranial spinal radiation. And of course, this symposium later with Dr. Brenner is going to talk about other ways to radiate people. Shameless self-promotion comment number one is the protocol that we have available with Herceptin and Perjeta that Dr. Ahmed is leading at our center, which is still open. There's a couple trials open at MGH, Dana-Farber with Nancy Lynn and Priscilla. And of course, Isabella has a bunch of trials, and I was doing the Nevo-Relatinib, which is pretty cool. And our trial I'll tell you about later. So standard of care, I think most people still need an Ommaya reservoir. Not everybody could agree with that. It allows instant access, and you can really intervene if patients have a problem. Maybe everybody doesn't need that if they have an EGFR responsive tumor, or maybe for breast cancer. There's data I'll show you in a moment about the HER3 DDX, and maybe some of the HER2 agents as well. You need a shunt if they have increased intracranial pressure. Need the proton cranial spinal given either with protons or IMRT. And then I don't know if this is indicated in all tumors. Many people think, like Isabella does, I think, melanoma is pretty resistant, and maybe that should be spared up front. I think intrathecal chemotherapy works. I can't prove that to you, and there's never going to be a trial about that. And then another paper by Bella shows that IV and IT nivolumab is effective in melanoma LMD, which we do all the time now. This is a pretty interesting paper, actually, the HER3 DDX, which is a HER3-associated antibody-dependent drug conjugate. And this is pretty amazing that the average survival was about 11 months, which Matthias Pruser did, which is really interesting. Now, how it is that an IV HER3 antibody has activity in the CSF is not at all clear to me. But, you know, it's pretty interesting. And of course, we really don't want to put Ommayas into everybody. You know, we'd rather just give them an intravenous or something. So that's a quick overview of state of the art, in my opinion. Now this, this is a practice. Well, I don't know, this changed my life because I read this paper by Adrian Bohr, which was available early on BioRx, you know, so it's available before it's published. And it showed that LMD is an inflammatory disease. Now, I always thought that LMD was a whole bunch of tumor cells floating around in this watery fluid, you know, and that's all there was to it. But it turns out that most of the cells, maybe 90 or 95% of them, are all immune cells, which of course is therapeutically interesting and biologically interesting. And there are cytokines such as interferon. So patients try to fight the LMD, which they do by secreting a little bit of interferon gamma. It does some maturation to the dendritic cells, and then it kills some of the tumor cells with this innate NK-mediated immune response, not the adaptive NK part. So we took this and started working on dendritic cells because of this, and really wanted to elicit an adaptive response. So I'll show you quickly. But this is kind of a primer about the dendritic cell therapy as it interacts with CD4s and CD8s. So it turns out that in mice, anyway, and we think in people that it's a CD4-mediated thing and not a CD8-mediated thing, as well as a B-cell-mediated thing. So we think that that's the appropriate mechanism. We also showed that in mice, it's B-cell dependent, so we can ablate any therapeutic effect with this. And then briefly in mice or in people, we collect their cells from either a port or an IV. You grow them up with about a cocktail of cytokines, and then we administer them back into the Ommaya reservoir once a week for 3 months. Just pretty wild, right? So we're educating somebody, we're educating your own immune cells so that they can recognize the HER2 and HER3 peptides and putting them back in the brain. And then there's not enough time for all these data, but in the first 6 patients, we looked at the transcriptomics in detail that I'll show you in a moment. And so far, one patient died out of the first 6, which is pretty amazing, and the average survival is 15 months. So far, not a median survival, so it gets longer every week. So there's something going on, there's activity, in my opinion. So this is Heather. I want you to remember Heather. The top row is just doing the single cell transcriptomics. The bottom is after treatment. And you can see that she had a whole bunch of tumor cells up here, and there's now fewer, hence the red circles. You do wonder, though, about these little bluey green things, right, that are persisting after treatment. What the heck are those guys? But we do get this induction of B cells and both naive and memory cells, as you'd expect. And you can see a whole bunch of more CD4 and CD8 cells and some more NK cells. So other than talking about this trial, the point is that this is an immune playground. So you can imagine there's a whole bunch of ways to affect any of these immune cell types, right? So there's a number of ways to knock down the macrophages. There are a bunch of macrophages probably, and they don't help. She's alive and well. She just passed her 2nd anniversary. And then we do have a plan with this DoD-funded thing. So now the next in January, March, we're going to do the phase 2 study of dendritic cells plus intrathecal Herceptin or intrathecal Nivo, thanks to Bella, in the HER2 negative patients. So, almost nobody in the room knows who Bob Dylan is, by the way. I won a Nobel Prize, but not for medicine or physiology. But it's super interesting because the times are changing. I mean, it's a new world, and I think it's time for us to stop thinking that leptomeningeal disease is incurable. It's a really bad attitude to have, and I think if you can change the way you think about it, then we have to start behaving in a way that recognizes that there is something we can do about it. There's a whole bunch of little comments here that I'm going to run out of time for. But once you want to cure something, it means you have to work together and you need a team. And you need to share, and to be nice. Now you need to share. And the LMD group is super sharing and very, very pleasant, and we really want to help each other. So finally, look, I censored myself. Finally, there's a bunch of amazing people that allow me to do this work, which I'm super grateful for, such as the Smalleys. There's Jessica Wilcox and Carrie Anders, and of course, the wonderful Dr. Pina. Dr. Janicki is the dendritic cell person, not me. Vincent, who has the crown here, really did all the work, almost all the data you've seen for the past 4 or 5 years. Been here. Cameron's amazing. Priya's been a great advisor. An unsung hero to me is Nam Tran, who is a neurosurgeon, and he is just fantastically supportive and wonderful. Often I'll send him a patient and he'll say, well, isn't she a candidate for your trial? And I'll say, oh yeah, I forgot. But we really can't do this stuff, and this is our funding. We are hiring scientists and postdocs if you're interested. So 44 seconds over. Thank you. Thank you very much.
Thank you to Forsyth. For the sake of time, we're just going to continue with the next presentation, and at the end, we're going to have all the questions, okay? So next, we're going to have our friend here who is amazing. She's a professor at Northwestern University. She's also the director of brain metastases. She's one of the leading experts in brain metastases as well, and does conduct a lot of research and clinical trials. And she's going to be presenting about clinical trials and design.
Great. Yeah. I have to keep it on time, so I thought I'd stay close to the podium because Peter kept it right on time. So these scientific breakthroughs are so inspirational. And when we are fortunate enough to work with great scientists like Dr. Forsyth, Dr. Boer, Dr. Kolitz, all of this data that you saw today, we want to take that and we, of course, want to produce the best clinical trial that then makes that therapeutic successful. So how do we do that? It's nuanced in this field. And so I do, it's uncharted territory. This is Lewis and Clark for those of you guys who don't like history. So I always have this slide, so I apologize because I'm sure any of you who've seen me speak, I always just put things into perspective. So much of what drives, I think, the folks in this room is leptomeningeal disease is so common, yet we haven't put the same amount of emphasis in trials as we have in other also very important diseases to many of us, like glioblastoma, which is another area that I work in clinical trials, and I'm sure many of you do as well. What I do want to say here is that I'm sorry that I've been using this slide for 6 years. I have been updating it though each time, and the updates are really heartening for me because I started with this number on the right, this 154 being around like 32 when I first made this slide in 2019. And so every time I update it, it's actually a little bit of a sunshine in my day because I do think that we are moving in the right direction and we're moving towards really becoming more active in this space and understanding that there is hope, to Peter's point. So we really, before we design the studies, we need to understand the challenges so that we're poised to overcome them. The first, and really importantly and near and dear to my heart, is that there is not a validated response rate in this disease, which means the foundation that you're standing on in order to see if this drug works is a shaky one. So we need to make sure that we have that as solid as possible. It's a heterogeneous population. When we say lepto, we're actually talking about a slew of different diseases biologically. Yes, there are some overlaps in those Venn diagrams, but breast and breast subtypes, lung subtypes, melanoma, et cetera, are all different biologic diseases, and we need to reflect that in our studies. It's a fragile population, and I'll talk about how we can overcome this when we're accruing to studies, and again, endpoints are challenging. I already know I need to speed up a little, so we're going to 2-in-1 some of these challenges, and this is the response rate and validated response. So we know that diagnostics in leptomeningeal disease is challenging. Radiographic disease falls short, following clinical state falls short, and CSF cytology also falls short. I'm not going to spend time on this because this audience knows it very well. So then how do we overcome this shaky foundation of endpoints in clinical trials? We need to have endpoints that are reliable, validated, and really importantly, reproducible. So for example, cytology here on the right, when we're looking at abnormal cells, we can get a positive cytology in our patients with lepto, but is that reproducible on 2 weeks later when you're rechecking? If it's negative, is it really that the disease has gone away? Or are you getting negative cytologic results because cytology is not very reproducible or reliable? So we really need to make sure that the endpoints that we select are solid footing. So there are a lot of different platforms being developed in CSF testing. I'm not going to go into detail with all of these, but you all are familiar. We're looking at tumor cell enumeration in the CSF. We're looking at cell-free and tumoral DNA, cancer cell genomes, epigenomes, methylation profiling within the CSF, FISH testing, and of course aneuploidy. So these are all things that we are now looking at, and many of them are in the CLIA certified realm as well. I get a lot of questions on CTCs versus cell-free DNA or ctDNA. There's pros and cons for each, and it's probably a little bit beyond the scope of today's talk, but we do need to consider some of these pros and cons in what we're weighing when we're talking about following a response, particularly when we're building a trial. So, tumor cell enumeration or CTCs really allows that quantitative marker that you can solidly follow. It's reproducible and reliable, and might even allow epigenetic testing down the road to be easier. ctDNA, there often is a higher abundance of that, so that can be in some ways more sensitive. It can be more reflective of a genome-wide background, unfortunately could have other DNA contaminants. And it's the hard thing that I find when we are looking at ctDNA is, what does it really represent? So if it goes up a little, are we looking at the disease worsening? Or are we looking at the disease being impacted by treatment and cells lysing, and then we have an increase there? I think that these are all questions that we still have, but thankfully I think are answerable. So what do these diagnostics offer an endpoint that those first three I mentioned, so clinical, radiologic, and cytologic, don't offer? These offer accuracy, sensitivity, quantifiability. There's trends that you can follow. So not only can you see what's happening over time, but you might even find early progression before you see it on an MRI. We've had at least one study where in the CSF we were able to show early progression in our CTCs prior to those changes on the MRI by like 8 weeks. That was our intrathecal trastuzumab study. And then super important is reproducibility. We would never do a science experiment that's not reproducible in the lab. Why would that be any different in the clinic? The clinic is, I always say the clinic is my lab also, and I want reproducible results there as well. So we need to think about these as we're building studies in leptomeningeal disease. One such platform that we use consistently and that we used in a study that Dr. Brenner is going to talk about right after me is this CNSide platform. And this, essentially how this works is it's CNS tumor cell enumeration and cell-free DNA detection. So the CSF is sent via this tube called the C-Shore tube. And I think it's important, the devil's always in the details. This tube keeps the sample stable for at least 96 hours. So you can ship it overnight and you can ensure that it's going to get there intact. And it's probably longer than that, but at minimum that amount of time. The reason why I think things like that are important is because we can develop all these new tools, but if they're hard to use and hard to access, meaning if I needed to send it on dry ice and take it by a courier pigeon within 2 hours to the lab, it's not going to work. So it's got to be functionally possible for patients and clinics to actually participate. So anyways, the tube. So then you have the CSF and it goes down two different workflow pathways. The first is an antibody cocktail tumor cell isolation. So it's basically the CSF goes through the microfluidic channel and there's antibodies that then grab at that and then you can count the cells. There's also once you capture that, there's also a cell-free DNA detection workflow pathway that's basically NGS on those. And then you can also perform tests such as FISH testing on this. So it really allows for in-depth testing on the CSF and actually allows it to be done in a very practical manner. So with CNSide, we had many retrospective analyses showing utility. Prior to the Forsyth study that I'll show you on the next slide, we had no prospective study to date. But what we found with these retrospective studies is that CNSide helps to diagnose leptomeningeal disease, helps to determine response to LMD-directed therapy, and helps to inform specific LMD therapy selection. So we have all of these possibilities with one diagnostic tool, but there was no prospective data in a controlled setting to actually confirm this. And what we really wanted to confirm was clinical utility. Is it actually helpful in the clinic, right? That's what all of this comes down to. Is it helpful for treating our patients and in those decision makings? And so essentially, and how does it stack up to our current gold standard, namely CSF cytology? So with that, we designed the prospective 4C study. really trying to answer these three questions. Is there a tumor? Is there a target? Is there a trend? And essentially we did at concurrent time points the standard of care diagnostics as well as CNSide. So we presented this last year. I didn't go into it in too much detail here. Dr. Brenner is going to talk about its impact in the ReSPECT-LM study, but essentially we found that it was widely high patient utility in all of these situations, whether it's treatment selection, disease monitoring, and disease trending. It's really important when we are thinking about these studies that we don't just say, this is going to accrue just like this other population will accrue, namely, for example, glioblastoma, which again is another disease that many of us take care of. The logistics are impacted by the outcomes of these patients. So this is, as you guys know, this is a population that doesn't do as well. So you're going to see if their survival, let's say, is 2 to 4 months, and you are spending 2 weeks to get them on study, which is very typical for a glioblastoma study, you're going to have many patients fall off because of that. So the speed of LMD progression and patient enrollment is key. So if we are going to do more studies in the LM population, we cannot just copy and paste from what we know from primary brain tumors. We got to do it differently. We need patients to be consented, screened, and registered fast, not weeks like other studies. We need, for phase 1 dose escalation, that can be even harder because, especially for multi-center, if the study's opening and closing, you can't have a patient wait 3-4 weeks for a study. That's too long. And then ultimately for the patients who can sometimes make it through these hurdles, does that actually represent the true population? So we want the studies that we build to represent the population that we're actually going to treat once hopefully that drug is approved. All right, but all of those hurdles being said, I do, like Peter, want to end on a positive and hopeful note, which is that we got this. We have more studies in LM than we ever have. It's been really amazing to see this evolution, particularly over the past 10 to 15 years. And our biologic understanding, as Peter's outlined, has tremendously evolved, not only over the past decade, but just even over the past 3 to 4 years. And we're learning from these mistakes. I think our community in LM is so special. We talk to each other about these studies. We learn what we've done right, what we've done wrong, so that we can emulate those right pieces in other studies moving forward. So I want to keep that community in LMD moving forward. And I always have a slide about hope, which is usually a set of trials, but Dr. Forsyth perfectly outlined that. To me, these clinical trials are hope. And making sure we are building them correctly for success is a part of that. All right, so LM is, of course, understudied with inherent challenges, but we're moving in the right direction. We need a validated response measure as the foundation for LM studies. And there are newer diagnostic tools and novel clinical trials on the horizon, and that's my segue actually to Dr. Brenner. But I will also, in that segue, put in a plug. For tomorrow, there's an Advances in LM session, of which at least 3 of these things are going to be discussed. And so these are the 3 abstracts that will be discussed tomorrow, including some more data on CNSide and some of what we learned there, as well as what you're about to hear right now. So did you want to enter?
Thank you, Dr. Kumthekar. So it is my pleasure to introduce a fellow Texan, Dr. Andrew Brenner, who is a professor in the Division of Hematology Oncology at the University of Texas in San Antonio. While it sounds like his training was primarily in Texas, Lubbock, Houston, San Antonio, I can really say he's an internationally renowned expert, and we're excited for him to really talk to us more about the development of rhenium in CNS malignancies. So thank you so much.
Thank you, Bella, and I appreciate the opportunity to talk about rhenium obisbemeda. We've been working on this at the Health Science Center for well over a decade now. And so what rhenium obisbemeda is a liposome encapsulated radiotherapeutic. We developed a custom molecule called BMEDA, which is a trident-like structure which has 2 sulfhydryl groups that basically interact with the radioisotope. At a neutral pH, it is lipophilic, but when you get into a slightly acidic environment, it becomes charged, is no longer able to leave the liposome. So we're able to achieve very high concentrations of radiation within a liposome. So it's the first liposomal methodology for radiotherapeutics. The liposomes are made of DSPC and cholesterol, basically the same as the cell membranes, and they're about 80 to 130 nanometers in size. The liposomes achieve two important things. One of them is they allow for retention in tissues. If you take radiotherapeutics and inject them directly into tissues, they readily enter into the circulation and are eliminated through the urine and the bile. But once you encapsulate them, the liposomes allow them to stay into tissues. And you can see that there in the middle, that the retention is really a factor of the decay rather than clearance. And then they also aid in dispersion. They help to increase the spread through tumors and other tissues, whether convection or just passively, just because of the significant increase in size. So, we first studied rhenium, obisbemeda, and GBM. We applied it using convection catheters into tumor tissue. This was a SPECT-GBM study, just using neuronavigation for catheter placement, and then just the patient, after they wake up after catheter placement, goes to a nuclear imaging suite where we infuse it using catheters. And you can see here, 40 minutes into the infusion, we can see that it's well within the tumor. It is not leaking into the surrounding surgical cavity, which you would typically see with most small therapeutics. And then it stays there. There are 6 hours, 24 hours, 120 hours. It doesn't really leave the site of placement. And then you can see over time, this is the patient in the whole body SPECT scan. And basically, it's just in the place where we placed it. You can see the catheters leading to it. They're pulled out after 24 hours. And then it's just a matter of decay with a little bit of elimination in the bile there at 7 days. In the phase 1 GBM study, we're able to dose escalate all the way up to a dose of 41.5 millicuries, and decided on 22 millicuries as recommended phase 2 dose. And then we saw evidence of responses, and we also saw a dose response where when we got into the higher cohorts and had patients with greater than 100 gray, we saw median survival around 17 months, which we recently published in Nature Communications, and it was really dose-dependent response. In terms of LMD, it makes sense for rhenium, obisbemeda, and LMD for a couple reasons. Number one, the path length. The path length of rhenium 186 that we chose to use in this particular liposome is about 2 millimeters. If you consider the cortical ribbon is about 2.5 millimeters, that means that the path length allows it to fully irradiate the surface without damaging the white matter. Most of the injury we see in the brain is due to the actively replicating cells within the white matter, which are completely spared due to the path length here. So we're able to get good coverage of the spinal fluid as well as the cortical surface without injury to the brain. When we first looked at this in our animal models, you can see on the top there, we did non-tumor bearing Wistar rats and just injected into the ventricles. We went up as high as 1.34 millicuries, and if you consider that the very, very small volume of CSF in a rat, that was a pretty tremendous dose and really correlated to over 1,000 gray. And the animals had no significant toxicity. Matter of fact, when we sacrificed them months later, the only thing that we saw was some meningeal hypertrophy from the placement of the needle, but no injury from the actual radioisotope. When we looked in tumor-bearing models, you can see there the MDA-MB231. We saw a decrease in tumor burden by luciferase imaging as well as increased survival. That led to our phase 1 dose escalation trial, the RESPECT-LM, which is a multi-dose study that was funded by CPRIT and 2+ Therapeutics. And the primary objective of this was safety and tolerability, and really was a basic 3+3 modified Fibonacci phase 1 study, starting with 6.6 millicuries, dose doubling all the way up to cohort 4. And then after that, we basically did 50% and then significantly dropped off in terms of escalation. Basically, patients had a CSF flow study to make sure there was no flow obstruction, to make sure that the liposomes would be able to circulate within the CSF. And then on day 1, a 5-minute injection in 5 mLs, similar to what we do with IT chemo, just right through the Ommaya reservoir into the ventricle, and then a little flush, and then we monitor them by SPECT CT imaging. Again, we started with 6.6 millicuries and worked all the way up to 75 millicuries. Cohort 4 dose was our recommended phase 2 dose. It was 36 patients enrolled, 7 screen failures. We saw a single DLT in each of cohort 5 and cohort 6. The dosimetry, which I'm going to show you in a moment, was one of the reasons why we went up so gingerly from cohort 5 to cohort 6. We're starting to see evidence of blood absorption, which correlated with thrombocytopenia. But otherwise, especially through cohort 4, there was really no significant grade 3 or grade 4 toxicity. And you can kind of see it here. There was 1% with grade 3, grade 4 toxicity through the entire phase 1 in terms of headache. And then, but the DLTs were really the decreased lymphocyte count and the thrombocytopenia. This is an example of the distribution. The top shows a patient in 3D, and the small little circle there is a standard that's placed near the patient. And you can see it in the lateral ventricle. It's just sitting there right after administration, as you'd expect. And then on the right, you can see similar from a static image. And then after 24 hours, it has completely redistributed, left the ventricular system, and has been absorbed along the surfaces of the brain and spinal cord to basically treat the entire CSF. This is whole body planar imaging, so you can see the patient in entire view there. Again, 3.5 hours mainly in the ventricular system. By 24 hours, it's completely left the ventricular system, is absorbed along the leptomeninges in the cranial and spinal space, and it stays there and just decays there. In our very first patient, we saw already a pretty significant response, which we didn't expect given the small dose that we were starting with. But the patient started with 70 cells per ml based on the CNSide assay, and by 48 hours had it dropped to 6 and remained there 14 days post. This is the overall dosimetry for both the target area, the subarachnoid space, as well as the organs of interest in terms of toxicity. And again, a dose-dependent response with cohort 1 starting around 28 gray to the cranial subarachnoid space. And by cohort 5, we got over 250 gray on average to the cranial subarachnoid space. So basically, you're talking with a traditional dose of around 30 gray with external beam radiation. We're looking at 7 to 8-fold of what you can achieve with external beam. When you compare that to the organ absorbed doses, we were getting up to about 2 or 3 gray to the blood. And that's if you look in the bottom there, general toxicity limits, that's really where toxicity is seen as mainly bone marrow. You can see liver and spleen, but we didn't get anything approaching that. And so the couple cases that we saw of thrombocytopenia were those patients that had blood absorbed doses of 3 to 4 gray or around that area. Again, suggesting that cohort 4 was the most appropriate safe dose. And again, it's important to note that this is from a target to non-target ratio. We're talking about 100 to 1. We're getting 100-fold absorbed doses to the cranial subarachnoid space compared to the organs of interest in terms of toxicity. In terms of responses, we looked at both CNSide assay. We didn't have it for the entirety of patients because the assay became unavailable for a short period of time. But in those we had it, we saw 13 out of 15 that had a response. 1 was stable disease, and then we only went out to 4 months because, again, as a phase 1 study, patients often went on to continue systemic therapy. But 13 out of 15 evaluable had a response by CTC, by imaging, 5 out of 16. And clinically, we had 2 patients that had substantial neurologic improvement out of 14 evaluable patients. This is a swimmer's plot for patients and their survival, with the median survival there for lung cancer and breast cancer noted at about, somewhere around 4 months. And the median survival for this patient population, even though it was a phase 1 dose escalation study. We had numerous patients that did quite well over a long period of time. For example, that very first patient up there was a patient with triple-negative breast cancer who did so well. After a year, she started showing signs of progression, and she hadn't received any other systemic or other treatment, and she asked for an additional compassionate use dose, and that was granted. And so she received a compassionate use dose a year later, and then went on for another year and received another compassionate use dose. after that, and she's actually received a total of 4 doses at this point. And then you can see a few other patients indicated by triangles that received additional doses. So it was encouraging. This is the immunosurvival for the patients through cohort 4, again, 9 months. This is where we are currently. We've completed the phase 1 trial. I'm going to show some additional data in terms of the overall survival and the MTD and then some biomarker evaluation tomorrow. But the recommended phase 2 dose was 44 millicuries as a single dose. What we're doing now is we moved on to dose optimization, seeing that patients are able to receive multiple doses. The question becomes, can we give multiple doses, what dose and what frequency? So we're starting with 13.2 millicuries at 2-month intervals. And then our last patient in that cohort should complete within the next few weeks. And then if those patients all do well, we'll move on to 1-month intervals. And then we're going to consider additional higher doses as well. So again, tomorrow we'll have updates on the phase 1 study, including some pharmacodynamic data, as well as the Forsyth data will be discussed as well. And then at this point, I'll stop and I want to thank all of the different collaborators of the different institutions. This was a multi-institutional effort. Dr. Kumthekar, Dr. Youssef, Dr. Schulder, and numerous others that contributed to the study, and of course to our patients.
Maybe I'm just going to speak very loud. They don't seem to be working. So Dr. Brenner, maybe, oh yeah, we don't have to touch it. That's fancy. Dr. Brenner, maybe starting off with you. So exciting data, right? 9 months. Can you maybe speak a little bit about radiation post patients received treatment, safety, radiation prior? And what I'm thinking about is really what Dr. Kumthekar just mentioned, that not every LM is the same, right? We have more the nodular LM, kind of the bulky versus maybe more diffuse thin. So maybe just a few things when we're thinking about how we might be able to implement this in the future for our patients, what your thoughts and experience have been based on the patients that you've seen and the MRIs.
I don't think this one's working. I'll speak loud too. So that's a great question. Because of safety concerns, when we did the phase 1, the FDA requested that we do not allow patients who received whole brain radiation or significant doses to the spinal cord to be enrolled. And so those patients were not eligible, but patients did receive radiation afterwards. A number of them, we've had a couple that went on to craniospinal irradiation with proton, and we had many that had involved field radiation afterwards. There was no evidence of any toxicity in those patients from what we're able to gather. Obviously, there's no formal analysis of that since it's just a few patients. And then we are in the current study, because the safety that we observed in this current phase 1 in the multi-dose, we do allow some spine irradiation as long as it's within reasonable limits, and we are allowing patients who had prior whole brain radiation.
Thank you.
Thank you. And Natasha Gatson, thank you so much for this, really awesome. I run into the issue where if there is some hesitancy by the medical oncology team specifically to move forward with intrathecal chemotherapy or some other systemic therapy, if they don't see any evidence of disease in the body, after radiation, they just don't do much of anything, and they're kind of watching. And I've run into that issue several times, and it's really hard to offer patients more radiation later, if they need it, especially if the disease comes back. I wanted to find out what has been your experience, or have any of these patients here gone on to have immunotherapies after this? As we know that sometimes immunotherapy, status post radiation, especially like SRS, things like that, can have an increased risk for radiation necrosis. Have you seen any of those cases?
So at least in terms of rhenium and obisbemeda, we had a few patients that had failed immunotherapy, especially the triple negative breast cancer patients often had received immunotherapy. In that case, I can say that we didn't see any evidence of injury. The biology is very different between this radiotherapeutic and traditional external beam radiation. You're giving a very high amount in a very short amount of time, but you're fractionating it out. But in terms of the dose per second, it's tremendously higher with external beam. This is just a continuous long-term radiation. So the biology in terms of radiant necrosis might be different. I did have one patient that one patient that I mentioned who had a triple negative breast cancer, the very first patient. After her third dose, we immediately moved her on, I think it was day 7 or day 8, based on some preclinical data, to immunotherapy. And so she received the compassionate use dose, and then a week or 2 later, she went on to Keytruda, and she had no evidence of significant radiation injury. But that's, again, these are small numbers, so it's really hard for me to answer that.
Do you have any data about the uptake, the lipoparticles and where they're uptaken? Excuse me, hold on, just let me finish. So specifically with the tumors, and is there a difference with the tumor cells, and then which immune cells is it taken up into, like Tregs, hopefully?
Yes, not published data. So I'm going to share a little bit about the bulk RNA sequencing that we did from these patients. And we had relatively 15 matched at various time points where we did bulk RNA-seq. We have done in animal models a more definitive assessment, including flow cytometry for the various different cell populations, what happened, et cetera. The indication is that the bulk of non-tumor absorption is by macrophages. We see a loss of macrophages by day 28.
Great.
So the macrophages, especially the M2s, are gone by day 28. So in other cold models, not LM, but in other cold models, for example, the ID8 aggressive model, which is a peritoneal model, peritoneal ovarian, we see that immunotherapy does nothing, but when you combine these two together, you get a synergistic response.
Have you knocked out the M2s to see, is that the effect, or is it uptake by the tumor? Like, we all assume it's uptake by the tumor cells, but can you know what I mean? Is that?
Yeah, it's
the biology is actually M2 mediated macrophage depletion, which would be pretty cool, right?
Yeah, so that would be a really cool experiment, but not something we've done so far.
And expensive, fortunately.
Yeah.
Cool.
Are there any questions? Yes, please. Sorry, we'll make you come all the way up to the microphone.
Thank you. I actually have 2 questions. First of all, I noticed that survival rate of LMD from melanoma is much shorter than LMD from breast cancers, primary breast cancer. Do you have any idea that what would be the reason? Is there genomic profiling of those cases are already published? And the second question is about cell-free DNA in CSF. When you isolate DNA, how do you make sure that the fragment is coming from tumor cells, not normal cells? Thank you.
I can maybe just talk about melanoma. We don't really know the answer. I think it's been repetitively described that melanoma from all the solid tumors has the highest incidence of LMD, but also the poorest survival. And I think we really not truly understand why that is, but you're right that breast cancer historically has been better, maybe double or even triple in survival. And I think Emily Leroux, I don't know if she's in the audience right now, but she published a beautiful paper in 2013 that really listed all the trials until then, at least, that really shows you the different survival. So it's been striking. As for the second part of the question, I'm going to give it to Dr. Kumthekar.
Anyone?
She's grabbing the microphone.
Okay, so I echo what Bella said. We don't fully know, but we don't know all the whys, but we definitely know that that breast cancer LM does better. We also know that HER2 positive breast LM does better. And so while I couldn't articulate every reason why. What I will say, and part of what I was trying to show, is that when we do build studies, then if you're going to, for example, build a study where the primary endpoint is OS and you're going to have all of those populations intertwined, you need to take that into account, because you're inherently, even without even putting a drop of whatever therapeutic in yet, you're already going to get different results, because we just know inherently. So I think while I'm not answering your question, I wanted to tell you kind of the why we were conveying that today. But there's a lot of hypotheses behind that we can get into offline. To your second question, which I do think anyone else can answer too, but I'll just hop in. The CSF is a pretty paucicellular environment, so it's a little bit different than, let's say, distinguishing maternal versus fetal DNA, circulating DNA for, a pregnant woman when you're assessing that versus in the CSF. I do think, I don't know if you have any, you probably would have wiser things to say here, but add on as you guys feel free, but I think that's a little bit less of an issue in the paucicellular environment of the CSF. Or do you have anything to add to that?
I just wanted to add kind of how little we know. So we all assume if somebody has melanoma, that what's in their CSF is melanoma, and it has the same characteristics as the tumor outside the CSF. There's no evidence that that's true. Like, we need to stop messing around and assuming.
Yeah.
So we had one of our patients who we treated, for example, who had triple negative breast cancer. When we did single cell later, which is after she died, unfortunately, she had HER2 and her 3 positive cells. So it's just an example of, we can't assume, and there might be specific vulnerabilities or resistant mechanisms that are enhanced in that environment. The problem is that it's really expensive and time consuming to figure out, but there's not going to be shortcuts, I think it's just going to be hand-to-hand combat.
Maybe I can ask Dr. Forsyth for another comment. So you have now a patient showing up in your clinic, and I don't even want to put a tumor type on, but definitely systemic therapies have been used up. There's really nothing else that you have orally or intravenous. So how do you actually choose what to do next for this patient right now, or what are maybe some, you're hating me right now, the head shake, but what would you do?
First of all, I hate you.
Because there's a lot of things, which I think what we're trying to show today, that there's a lot of things we don't know, but there's been tremendous improvement. And meetings like this get people together and think and discuss what we are missing, and how especially the more junior people really need to get to work and help us solving the problems. But how would you treat a patient now, Peter, where you have this clinical trial available, you have your own dendritic cell trial, you have intrathecal chemo, you have whole brain? What would you do, and how do we approach actually from a patient perspective the what's next? I think that's important too.
I really do hate you. It's a great question, and I'm not sure I can really answer that other than to say we do try to interrogate as much as we can the CSF, what we can in real time. Every once in a while we do single cell, which of course can't influence patient decisions. It takes a long time. It's pretty expensive, probably about $15,000 per patient. And really just trying to look and see if we can discover a vulnerability. And then I think it's sort of offering whatever the patient thinks is a reasonable alternative. The other thing is not to think of ourselves as a single cancer center, but we have to be aware of what clinical trials are available. So it'd be great, Elaine, if there was a single site, right, for clinicians and patients to go, well, I have leptomeningeal disease. These are the trials that are open. Because we all know clinicaltrials.gov is pretty evil, pretty punitive. Even I can't stand it. And so we do send people to you or Priya or anywhere around the country so that we can give them the best therapy. We do send them to Elaine as a independent, arbitrator, right, who doesn't have their own selfish desires and will look out for the best needs of the patient and all that. So, and we've sent people to, Sloan Kettering and Dana-Farber and other places, because I think the country is sort of the clinic. And so it's our, which I know you do, right? If somebody has a great trial, you send people anywhere.
Yeah, so I mean, I just discussed this earlier. So the Plus Therapeutics trial was not open at MD Anderson for LM, but in every single note of a patient that I see for LM, I do mention the trial. It's in my attestation. It's for the patient as a reminder with the website. Because again, I think in my role, as much as obviously we would like to help patients and enroll them on our protocols, I always consider my job to be as an educator,
Right.
so that they
An
really know
advocate.
the options. The same with Dr. Boas' trial in Sloan Memorial. I mean, I think this is, again, what I hope you all will take back and say there are options within the US, and really remind your patients and your colleagues that these options exist. I think it's incredibly important, and was a huge discussion today in our LM think tank that one of the biggest deficits the field has is the more global education of healthcare professionals and for our patients.
We also try to encourage people to bank for the future, because it's a terrible disease. So we get, CSF banking in case somebody discovers something tomorrow. And then not to mention an unpleasant topic, we make a huge deal of the CSF and single cell and all that stuff, but we have no idea if that's entirely interesting or useful at all in determining what's happening at the peel tumor cell interface. Since we don't do biopsies, we started, as other places have, the rapid tissue donation service, really without a specific question other than what Ian is doing, so that we have the reagents to make discoveries in the future, So I think patients are happy to do that by and large.
And I also want to add, I work closely with Dr. Forsyth and with our colleagues here. We have to change the culture of how we view leptomeningeal disease globally. It's not, we have to believe that we can do something about it, that we can find cures for it. Number one, like they mentioned, clinical trials. What clinical trials are out there? If there's no clinical trial available, the patient has good performance status, what can we do next? Even if we don't know, and there's really no evidence, the lack of evidence for a treatment doesn't prevent us from actually using it. We always go for something. We just don't say we don't have any options. So another thing that we advocate, placing an Omaya early on, I think it's important. I always recommend it, even if we're not planning right away to use intrathecal therapy, because it can be life-saving for these patients. And I actually am very, straightforward and open, and I tell the patients this, because sometimes they wait until the last minute and they cannot go to the OR to have the Maya. So all these are things that we have to keep in mind.
Are there any final questions? We have just 1 or 2 minutes left. Any questions, thoughts, comments? I know it is 7:15 p.m., but you're all enthused to make the world for LMD patients better, correct? Good. So I think with this, we again appreciate and thank our panelists for really outstanding presentations. We're looking forward to hear more data tomorrow. I do also believe we will have the poster reception going on next door. So again, I would encourage all of you to just grab a glass of water or your beverage of choice and just roam. There's some really wonderful posters out there with lots of information. And again, go back home to your home institutions and think about how we can change. Thank you so much. Have a good evening.